Hi, my name is Elisha Peregino. I'm a pediatric neurosurgery nurse practitioner at Penn State Hershey Children's Hospital. And today I'm going to talk about a quality improvement project that has evolved over time with our service, as well as one nursing unit at the Children's Hospital. So today I'm going to talk about utilizing nurse practitioners to facilitate bedside nursing involvement in multidisciplinary rounds. At the time of submission, I had put in for my 6-month data, and I will discuss a little further into 9 months today. I do not have any professional disclosures or conflicts of interest. A little bit of background: compared with medical services, surgeons and surgical services may encounter more difficulty communicating with nurses due to their daily workflow and frequent absences from the unit. Surgical services tend to have outpatient clinics, surgeries, as well as academic time, which makes it a little different than having a medical service that's housed on one single unit where nurses can frequently find providers and ask questions. Ineffective doctor and nurse communication has a potentially detrimental impact on patient care and the quality of care provided. There are several studies addressing physician and nursing rounding, improving patient care, utilizing checklists, yet there is limited research looking at surgical services, nursing, as well as rounding in the pediatric population, as well as the involvement of any type of advanced practice provider in multidisciplinary care rounds. Going back a little bit to the first quality improvement project that I presented the last conference, back in April of 2018, we launched something called the Nursing Neurosurgical Communication Tool, or the NNCT, which is pictured here to your left. The goal of the tool was to improve nursing and neurosurgery communication. Being involved in quality improvement with the unit, we had a subjective communication or conversation talking about how we needed to have an improvement in our team's communication about patient care. But then we also did a baseline survey that demonstrated there was a need for improvement of some sort moving forward for our service in this one unit. With nursing management, the surgeons, and myself, we came up with the NNCT, which is here pictured. We wanted to improve patient safety and the quality of care that we provided. And then we also wanted to allow for easier identification of the key team members, which are nursing as well as the surgeon, and how people can get in touch with them. Also at the time, nursing, they launched this face card initiative that had a nurse's face as well as their name, and then also a means of communication in terms of ASCOM or a cellular device for the teams to contact. To the left, the NNCT, it shows just a very brief overview of it. I'll discuss shortly. It covers the patient's diagnosis and then any neurosurgical or neurological exam concerns. This was a topic that was discussed with nursing, and that was an area that they felt that we were not great at communicating or addressing on part of neurosurgery. The rest of the tool looks at disposition type criteria in terms of whether or not the pain of the patient is well controlled, where the pain is located, if they're eating and drinking, voiding and stooling okay, if they need any type of therapy services to get them discharged from the hospital, and then if they were at risk for falls, and if there were any drains or infectious concerns. At the very bottom of the form, it did allow for a spot for nursing concerns as well as parental concerns. Around the 3-month mark, we did an initial data review with the unit that we did this project with. And so on the left, there is a bar graph that shows the first 3 months of hospital days. The total number of hospital days is in blue, and then the total number of hematology oncology unit days, which is where this tool was launched, are in red. So we averaged anywhere from a very low point for our service from 20 to 32 hospital days on the units. In the pie graphs, you can see months 1 to 3, and it shows the number of tools, the NNCTs, that were completed. We averaged from about 15% to 65% completion. And at this point, when this was presented to the unit, we had an initiative to raise awareness and educate the staff. There's a different color on here listed as well. That is the green, and it's completed by day shift. So the NNCT, the goal was that the night shift nurse would complete it prior to day shift coming in, and that would also highlight the last 24 hours of the patient's care. And so the goal was when the nurses had to go to bedside rounds with neurosurgery, which we round pretty early in the morning, sometimes as early as 7 o'clock, that nursing would be able to have a little bit more insight and information on their patients. So it was vital for the form to be completed for day shift nursing to be able to join rounds. So there were a couple of forms that were completed during day shift, which we just quantified in a different color. So that way we could tell the compliance and adherence with the overall team's plans. So at 4 months, we sent out a survey to all of nurses on this unit, and the following was demonstrated. There was a 30% improvement in addressing the nurses' concerns. There was a 10% improvement in neurosurgery and nursing communication. And then there was also a 9% increase in nursing confidence at bedside rounds. 61% of nurses felt that the tool actually improved their understanding of the patient's care. Despite all of these positive changes with instituting the tool, and also noting that there weren't a lot of the tools being completed, there still was this overwhelming response that was subjective from nursing that nurses were not being involved physically in bedside rounds. That is what sparked the idea for this project. So this is a prospective single institution, single surgical service line study with pediatric neurosurgery on the pediatric hematology oncology floor at Penn State Hershey Children's. There are 3 primary neurosurgeons that make up our team, as well as 1 rotating resident who comes on our service for 2 months, and then 1 APP, which is myself. And we currently onboarded a second who was not involved in this study at that time. We analyzed the method that we contacted nurses in terms of calling them on their ASCOMs or physically contacting them in the hallway, whether they were doing sign out, if they were at a nursing station in a med room, or potentially in the hallway, walking to and from a patient's room. And then we noted that the daily rounding style of both the surgeon and also the nurse practitioner, it didn't change. So the only variable that changed was actually how, keeping track of how we got in touch with nursing to get them to come to rounds and be a part of bedside rounds. The timing of rounds and the time spent at the rounds were collected for each patient to better understand surgical team workflow, as well as time spent at the bedside by nursing. Over 9 months, there was an average of 91% of nursing presence in bedside rounds. The method of contacting nursing to join, a quarter were called off of their ASCOMs, and then 3/4 were physically contacted for rounds. 40% of nurses did not have the contact face sheet, the picture of their face, their name, and their ASCOM listed on the outside of each patient's room per their unit protocol, but they were able to be contacted to be present in rounds. On average, rounds at the bedside took 5 minutes per patient. In our initial study, we also tabulated how long it takes to physically find a bedside nurse in the process of getting them to join bedside rounds, and it averaged about 8 minutes to physically find a nurse at times. And so that also is pretty significant when you look at doubling rounding time per surgeon, and you also have 3 surgeons. This is just a bar graph of nursing presence as well as the contact method utilized, looking at whether or not the nurse was called, if they were physically found, or if they joined without their name and number posted, and also if they joined. Over the 9-month period, there was a 81 to 94% presence by bedside nursing, with the majority of nurses being physically found. And you can see that the majority of nurses also, there were low points where nurses were called only about 16% of the time. After the data was presented to nursing at a unit accountability team or a UACT meeting, the verbalizations had decreased. The NNCT interim surveys also, unfortunately, did not demonstrate a change in communication, understanding of patient care or their plan for the day, or perceptions of improved nursing involvement. It also did not change the amount of nurse paging to the advanced practice providers or to the resident who carries the pager. So in conclusion, having an advanced practice provider, or in this case, a nurse practitioner, in multidisciplinary daily rounds increase the physical presence of the bedside nurse. This could also be a constant presence of another team member, such as a care coordinator. Unfortunately, from this study, it did not demonstrate that the content was saturating in terms of a plan, or it did not improve patient quality of care or overall team communication. Larger studies are necessary to generalize to other populations, not just the pediatric hematology oncology floor, but also other surgical service lines, as our workflow changes and our relationship with nursing is different. Currently, there is an expansion of this tool that's happening on the Children's Hospital Surgical Care Unit that is currently being led by one of our retired neurosurgeons. who was involved in the process of this project. I'd like to thank my neurosurgeons, Dr. Diaz, Dr. Rizek, and Dr. Akbari, as well as Dr. Ian Tosca for all their support in doing these projects in terms of quality improvement and improving communication, as well as the Department of Neurosurgery. For Penn State Hershey Children's Hospital, special thanks to the Hematology Oncology Nursing team, whom we miss very much because most of our patients are now on a surgical care floor after the expansion. And then also thank you to the Penn State Hershey Children's Surgery Center. If you have any questions, please feel free to reach out to me at the email listed below. Thank you very much for your time.